Hello everyone, I am Chetan Maurya, phase second MBBS student, Karwa Institute of Medical Sciences. Today I will be presenting a topic on acute rheumatic fever. This is an important disease because it can lead to rheumatic heart disease, which is a major cause of morbidity in developing countries. First, I would like to define acute rheumatic fever. It is a systemic inflammatory disease caused by an immune response to group A streptococcal infection. It mainly affects the heart, joints, skin, and central nervous system. Now coming to incidence, acute rheumatic fever commonly affects children between the age of 5 to 15 years when the streptococcal infection is most frequent and intense. I- Both males and females are affected, although slight female predominance may be seen. The disease is seen more commonly in poor socio-economic status of the society, living in the damp and overcrowded palace, which promote interpersonal spread of the streptococcal infection. There is an association between the presence of specific HLA marker and susceptibility to acute rheumatic fever. In first half century, decreased incidence of rheumatic fever due to improved public health, living condition, developed modern antibiotics. Now coming to now I will explain the pathogenesis, which is a very important. The disease occur after a group A beta hemolytic streptococcal throat infection, usually after 2 to 3 weeks. However, the mechanism of lesions in the heart, joint, and other tissue is not by direct infection, but by induction of hypersensitivity or autoimmunity in susceptibility host. Thus, three type of factor in etiology and pathologies of rheumatic fever. First, environmental factor. Second, host susceptibility, and third is a immunological evidence. First, the most important factor is a environmental factor. History of pharyngeal or upper respiratory tract infection caused by beta hemolytic streptococci is specifically group A streptococcus. This infection typically occurs 2 to 3 weeks before the onset of rheumatic fever. Recurrent or untreated streptococcal infection significantly increase the risk, leading to repeated attacks of rheumatic fever. The incidence of rheumatic fever increases during outbreaks or epidemics, especially in crowded settings like schools and training camps. Early and appropriate use of antibiotics plays a crucial role in reducing the incidence, severity, and recurrence of the disease. Socioeconomic factor: poverty, poor nutrition, overcrowding, and poor medical care. Geographical distribution: higher in developing countries, more in underprivileged population. Climate: more common in cold, damp, subtropical and tropical areas. Second is the host susceptibility. In host susceptibility, first, familial clustering of disease, occurrence in identical twins, association with HLA class second alleles, increased B cell alloantigen in first degree relatives. Third one is the immunological evidence. It has been observed that throat of patient during acute rheumatic fever may contain streptococci. The clinical symptom of rheumatic fever appear after a delay of 2-3 weeks, and the organism cannot be grown from the cannot lesions in the target tissue. This had led to the concept the lesion of immune pathogenesis. Patients with rheumatic fever have elevated titers of antibodies to the antigen of beta-hemolytic streptococci of group A, such as anti-streptolysin O and S, anti-streptokinase, anti-streptohyaluronidase, and anti-DNase B. Second is cell wall polysaccharide of group A. Streptococcus forms antibodies which are reactive against cardiac valves. This is supported by observation of persistently elevated corresponding autoantibodies in patients who have cardiac valvular involvement than those without cardiac valve involvement. Third one is a hyaluronate capsule of group A. Streptococcus is identical to human hyaluronate present in joint tissue, and thus these tissue are the target of attack. Fourth one is a membrane antigens of group A. Streptococcus react with sarcolemma of smooth and cardiac muscle, dermal fibroblasts, and neurons of caudate nucleus. Summary of organism or susceptibility immune hypothesis. Combining the three types of evidence says given above, pathogenesis of rheumatic fever, rheumatic heart disease can be summed up as under: a susceptible host on being encountered with group A streptococcus infection mounts an autoimmune reaction by formation of autoantibodies against bacteria. Second one is that these autoantibodies cause damage to human tissue due to cross-reactivity between epitopes in the components of bacteria and host. Third is a streptococcal epitopes, bacterial cell wall, cell membrane, and the streptococcal M protein are immunologically identical to human molecule on myosin, keratin, actin, laminin, vimentin, and N-acetylglucosamine. Fourth is a molecular mimicry and cross-reactivity between streptococcal M protein, the basis of autoimmune damage to human target tissue, rheumatic heart disease, cardiac muscle, valves, joint, skin, urine, etc. This is a diagram of pathogenesis of rheumatic heart disease. Now coming to pathology, the characteristic microscopic feature is the ASCO body, which is a pathogenic of rheumatic fever. It consists of fibrinoid necrosis surrounded by inflammatory cells. Microscopically, the heart valves, especially mitral and aortic valve, are affected. They become thickened and inflamed. And microscopically, focal nodule known as ASCO body, which is a pathognomonic of rheumatic fever. The nodule is formed by fibrinoid necrosis of collagen surrounded by lymphocytes, macrophage, occasional plasma cell. It may be found in all three layers of heart, joint, and subcutaneous tissue. Macroscopically, most obvious in the heart wall, the pericardium, the wall cusps become thickened by edema and by the infiltration of capillaries. These are common on the mitral or aortic valve cusps. Seldom affect the tricuspid or pulmonary valves. When the pericardium is involved, it becomes thickened, may contain a fibrinous straw-colored effusion. This is a scope body picture. This shows anti-scope cells, scope cells, mononuclear cells. Now coming to clinical features. First attack of acute rheumatic fever generally appear 2 to 3 weeks after streptococcal pharyngitis, most often in children between the age of 12 to 15 years with subsequent streptococcal pharyngitis. There is reactivation of the disease and similar clinical manifestation appear with each recurrent attack. The disease generally presents with the migratory polyarthritis and fever. However, the acute rheumatic fever has widespread systemic involvement, and no single specific laboratory diagnostic test is available. Patient of the syndrome of acute rheumatism develops lesions in connective tissue elsewhere in the body. chiefly the joints, subcutaneous tissue, arteries, brain, and lungs. The important clinical manifestations include polyarthritis, erythema marginatum, subcutaneous nodule, and arthritis. First, discuss about polyarthritis. Acute and painful inflammation of synovial membrane of some of the joints, especially the larger joints of the limbs, is seen in about 90% case of rheumatic fever in adults and less often in children. As pain and swelling subside in our one joint, others try to get involved, producing the characteristic migratory polyarthritis involving two or one more joints at a time. Second one is erythema marginatum. This is a non-pruritic erythematous rash is characteristic of rheumatic edema. The lesions occur mainly on the trunk and proximal part of the extremities. The erythematous area develops central clearing and has slightly elevated red margins. The erythema is transient and migratory. Third one is subcutaneous nodules. The subcutaneous nodules of rheumatic fever occurs more often in children than in adults. These nodules are small, 0.5 to 2 cm diameter, spherical or ovoid and painless. They are attached to deeper structure like tendons, ligaments, fascia, or periosteum, and therefore often remain unnoticed by the patient. Characteristic locations are extensor surface of the wrists, elbows, ankles, and knees. Fourth one is a rheumatic arthritis. Arthritis in rheumatic fever involves not only the coronary arteries and the aorta, but also occurs in arteries of various other organs such as renal, mesenteric, and cerebral arteries. The lesions in the coronaries are seen mainly in the small intramyocardial branches. Diagnosis is based on Jones criteria as per revised WHO criteria 2004, based on the revised Jones criteria first described by Dr. T. D. Jones in 1944 and last revised in 1992. Following major and minor criteria and some supportive evidence of prescribing infection are included for diagnosis. First is a major criteria. Major criteria includes carditis, polyarthritis, chorea, erythema marginatum, and subcutaneous nodule. And minor criteria includes fever, arthralgia, previous history of rheumatic fever, laboratory findings of elevated ESR, rise C-reactive protein, and leukocytosis, ECG finding of prolonged PR interval. Supporting evidence of prescribing group A streptococcal infection include positive throat culture for group A streptococci, rise titers of streptococcal antibodies, anti-streptolysin O and S, anti-streptokinase, and anti-streptohyaluronidase, anti-DNase B. Clinical diagnosis of rheumatic fever and rheumatic heart disease is made in a case with antecedent laboratory evidence of streptococcal throat infection in the presence of any two of the major criteria or occurrence of one major and two minor criteria. Diagnosis is made when there are two major criteria or one major and two minor criteria with evidence of streptococcal infection. Major criteria: low risk population, carditis, arthritis, chorea, erythema marginatum, splenosis. In high risk population, carditis, arthritis, monoarthritis, polyarthritis, polyarthralgia, chorea, erythema marginatum, and subcutaneous involvement. In minor criteria, in low risk population, polyarthralgia, high risk population, monoarthralgia. In low risk, hyperpyrexia and hyperpyrexia. Same. ESR greater than 60 mm per hour and high risk ESR greater than 30 mm per hour. NCRP greater than 3 milligram per deciliter in the same. Prolonged PR interval and prolonged PR both are same. Diagnostic criteria is initial acute rheumatic fever, 2 major or 1 major plus 2 minor. Recurrent acute rheumatic fever, 2 major or 1 major plus 2 minor or 3 minor criteria. If the heart is spread in a case of acute rheumatic fever, the patient may have complete recovery without any sequelae. However, once the heart is involved, it is often associated with reactivation and recurrence of the disease. Myocarditis, in particular, is the most life-threatening due to involvement of the conduction system of the heart and result in serious arrhythmias. The long-term sequelae or stigmata, chronic valvular deformities, especially the mitral stenosis, as already just explained. Initially, a state of compensation occurs, while later decompensation of the heart leads to full-blown cardiac failure. Currently, surgical replacement of the damaged valve can alter the clinical course of the disease. The major causes of death in acute uh, rheumatic heart disease are cardiac failure, bacterial endocarditis, and embolism. First, cardiac failure is the most common cause of death from rheumatic heart disease in young patients. Cardiac failure occurs due to the chronic valvular deformities, while in older patients, coronary artery disease may be superimposed in the old rheumatic heart disease. Second is the bacterial acute type may supervene due to inadequate use of antibiotics. Third, embolism in the rheumatic heart disease originates most commonly from mural thrombi in the left atrium and is appendages associated with mitral stenosis. The organs most frequently affected are the brain, kidneys, spleen, and lungs. Fourth is the sudden death may occur in rheumatic heart disease as a result of ball thrombus in the left atrium or due to acute coronary insufficiency in association with aortic stenosis. To conclude, acute rheumatic fever is an autoimmune complication of streptococcal infection. Early diagnosis and treatment are essential to prevent rheumatic heart disease, which has long-term consequences. Thank you.